Today, we're tackling a topic that is absolutely crucial, not just for your exams, but for your clinical practice down the line. We're going to demystify the umbilical cord and Doppler ultrasound in pregnancy. So let's get right into it.
Okay, so here's our game plan. First, we'll cover the basics of the umbilical cord, its anatomy, and how blood flows, which is kind of unique. Then, we'll look at what a normal Doppler looks like. After that, we'll get into the serious stuff. What happens when things go wrong, a condition called uteroplacental insufficiency. We'll even touch on some advanced things like MCA Doppler, and then we'll wrap it all up with a super high-yield summary for your exams. We're going to build this up step by step.
All right, let's begin with Section 1, the fetal lifeline. We're starting here because, well, you really need to understand why this amazing structure is so fundamental for the baby's survival inside the womb. Okay, let's run through the key features. A normal cord is about 40 to 70 centimeters long. It's cushioned by this stuff called Wharton's jelly, which is super important because it stops the cord from kinking and cutting off supply. Now pay very close attention to this next part. Early on, there are 4 vessels, but by term, there are only 3, 2 arteries and 1 vein. This is a classic exam question, so please remember it. And there's also this little connection called the Hertel anastomosis between the arteries near the placenta, which helps balance out the pressure.
Now we're at a point where so many students get tripped up. So let's make the unique fetal circulation crystal clear. I know it seems a bit backward at first, but trust me, once you get the logic, you will never, ever forget it.
So this is the one thing you have to lock into your brain. It's the complete opposite of how our circulation works after birth. The single umbilical vein brings all the good stuff, the oxygen-rich blood, to the baby from the placenta. And the 2 umbilical arteries take the deoxygenated blood and waste products away from the baby back to the placenta. Just remember this simple rule. Vein goes to the baby, arteries go away. Let's see it in action.
This diagram just shows the whole system so beautifully, doesn't it? You can see it right there, the red oxygenated blood flowing from the placenta through that single umbilical vein to the baby. And then, after the baby has used it, the deoxygenated blood goes back through the 2 arteries to the placenta to get refreshed. The whole thing is designed to be a low-resistance, low-pressure circuit for maximum efficiency.
Okay, so we've got the anatomy down, but how do we actually check on it? Well, that's where Doppler ultrasound comes in. Let's take a look at what a healthy umbilical artery waveform, well, what it looks and sounds like. This is basically how we listen in on that lifeline.
So this slide shows a really key change that happens over the course of the pregnancy. You see, early on, the system is high resistance. That means less blood flows forward when the heart is relaxing, during diastole. But as the pregnancy goes on and the placenta matures, that resistance drops way down. This allows a lot more blood to flow to the baby even during diastole. Seeing this change is a great sign of a healthy, growing placenta.
So why does this happen? What's the secret? Well, it's one word: progesterone. This hormone is the star of the show here. It causes this massive vasodilation. It makes the blood vessels in the placenta relax and open up. This lowers the resistance and lets more blood flow through all the time, even during diastole. This is a really important point, especially for your Viva exams.
And all of this brings us to the magic number, the one number you absolutely must remember. It's the S/D ratio, which stands for the systolic to diastolic ratio. In a healthy pregnancy near term, this S/D ratio should be less than 3. Think of it as our benchmark for good, low-resistance blood flow.
All right, now for the most clinically important part. What happens when this perfectly designed system starts to break down? This is when we start talking about a condition called uteroplacental insufficiency, or UPI. It's when that lifeline is under a whole lot of stress. Okay, you need to follow this sequence very carefully. In conditions like preeclampsia, for example, the resistance inside those tiny placental vessels starts to go up. This makes it much harder for blood to get through, right? Especially during diastole. As a result, the resistance in the umbilical artery goes up, and the blood flow during diastole goes down. This whole chain reaction is exactly what we see on the Doppler.
But Joe, this slide is extremely high yield. It connects what you see on the Doppler directly to what you need to do for the patient. If the SD ratio creeps up above 3, we start planning for delivery around 37 weeks. If the flow during diastole just stops, it disappears completely. We call that absent end diastolic flow, or AEDF. That's more serious, so we plan for delivery earlier, around 33 to 34 weeks. And the worst case scenario? That's reverse end diastolic flow, or REDF. This is an emergency and you have to deliver the baby very early, at 30 to 32 weeks to save them.
Now look very carefully at these two images. On the left, you can see the waveform. See how it just hits the baseline during diastole? That's it. Absent end diastolic flow. No forward blood is getting to the baby in that moment. Now look at the right. This is even worse. The waveform actually dips below the baseline. That means blood is flowing backward, away from the baby. That is REDF, a very, very bad sign of severe fetal compromise.
Okay, let's just quickly touch on two other important topics that are related to all this. We're going to talk about the middle cerebral artery Doppler and what to do when you find a single umbilical artery.
So the key here is to know which tool to use for which job. We use the umbilical artery Doppler to check on the health of the placenta, usually in cases like growth restriction and preeclampsia. But we use the middle cerebral artery, or MCA Doppler, to check on the baby itself, especially if we suspect something like fetal anemia. It tells us if the baby is trying to protect its brain by redirecting blood flow there. We call this the brain-sparing effect.
And for the MCA, this is the critical value you have to know. If the peak systolic velocity, the PSV, is 1.5 multiples of the median or higher, it's a big red flag for significant fetal anemia. Now, multiples of the median sounds complicated, but it just means the blood speed is 50% faster than what's normal for that age of the fetus. You often see this in conditions like Rh isoimmunization.
And finally, what you do if you find only a single umbilical artery, or SUA. This is the standard protocol. First things first, you do a detailed anomaly scan, because SUA can be linked with other problems, especially with the kidneys and the heart. If you do find a major anomaly, then the next step is karyotyping, to check the baby's chromosomes. But if that detailed scan is completely normal, then usually no karyotyping is needed.
All right, everyone. Let's do a very quick rapid-fire recap of the most important must-know points from our entire discussion. These are the things that you should have on your fingertips for your exams.
Please memorize these facts. The vein carries oxygenated blood. Normal S/D is less than 3. UPI means high resistance, low diastolic flow. REDF is the most dangerous sign. We use MCA Doppler for anemia, looking for a PSV of 1.5 mom or more. And a single umbilical artery means you have to look for kidney and heart defects. These points are huge for MCQs.
And to finish off, let's put this knowledge to the test. Here's a clinical scenario for you. You get a Doppler report. It says S/D ratio of 4.0 and absent end diastolic flow at 32 weeks. So based on everything we just talked about, what is your immediate plan? What is the next step? Think about it, because applying this knowledge is what really matters. Okay,